Hello, my name is Neil O'Toole, and I'd like to welcome you to this podcast, which is the latest in a series of podcasts by the Younger Parkinson's Alliance. Our vision is to create a world where the aspirations and challenges facing younger people with Parkinson's and their families are understood, respected and supported, enabling them to lead active and fulfilling lives. This podcast today is about medication. I'm joined on the panel by Dr. Annette, an Associate Professor of Complex Long-Term Conditions, as well as being a Parkinson's nurse. I'm also joined by a number of my Parkinson's colleagues, Hema, Kerry, Nick and David. Given that the subject of this podcast is medication, we would like to make clear at the outset that the contents of this podcast reflect the experiences of a number of individuals who have Parkinson's. Parkinson's disease is a complex condition which affects everybody differently, and the content should not be construed in any way as presenting advice to any individuals who have Parkinson's and may be listening to this podcast. I'd like to go first to Annette.
Hi, thanks for inviting me. My name's Annette Hand. I'm a nurse consultant and I work up in the northeast of England, and I've been looking after people now with Parkinson's for about 22 years. I'm also the clinical lead for nursing for the Excellence Network, and I also have another role with the University of Northumbria as an associate professor there, both teaching in prescribing and medication and also with research with Parkinson's.
Thank you, Annette, and pleasure to have you with us.
Thank
Kerry.
you.
Hi, I'm Kerry Hartman. I live in Shrivenham, which is in Oxfordshire, and I was diagnosed with Parkinson's when I was 56, which was 4 years ago. I was a school business manager at the time, and I found it hard to keep the job going, but I did keep going as much as I could. And I've now created a friendship and support group within my local area called Parkers Pals, and we all help each other get through this.
Great. Thank you. Thank you for joining us. Hema.
Hi, everybody. I'm Hema Riley. I was diagnosed in 2016 at the age of 51. I was a childcare social worker for 37 years. And I now run a local Parkinson's group for the South Asian community in Leicestershire, which is where I live.
Thank you, Hema. Welcome. Nick.
Thank you.
Hi, I'm Nick Cole. I live on the sunny south coast, and I was diagnosed almost 6 years ago now. I'm a registered nurse by background and still work full-time in the NHS. It's me.
Right, welcome, Nick. And finally, David.
Good evening, I'm David Allen. I'm trustee for Parkinson's UK in Scotland. I was diagnosed in 2011 at the age of 49. I've been presenting with symptoms for 6 years prior to that. I was living overseas at the time, and that's what led to me returning to Scotland. And this year is where I live. I'm now, in addition to being a trustee, a full-time volunteer for Parkinson's UK. I run a Parkinson's UK cafe. I set up a singing group, a dance group, a Tai Chi group, and various others.
Thank you, David. Well, thank you for making the time to join us today. We'll start with the clinical side, if I may, Annette. It'd be great to hear from you a little bit about the NICE guidelines in the UK as they relate to Parkinson's disease, and perhaps a little more about the prescribing competency framework, as well as the individual nature of Parkinson's disease and how it presents differently in different individuals. So over to you, Annette.
Okay, thanks, Neil. I've been prescribing now for about 16 years, and when I first started prescribing, there weren't any really guidelines to tell me what drugs I should be using in which order. And it was very much left up to me as an individual clinician to kind of work that out with the person I was looking after. Things have changed slightly over the last few years. So we've got NICE guidelines in Parkinson's, and NICE stands for the National Institute for Health and Care Excellence. Now, these are national guidelines that have been produced by experts in the field, and they take the best evidence there is out there that we've got on anything at all. So there's lots of evidence now about Parkinson's medication and drugs that we should be using. So in 2017, when they reviewed those NICE guidelines for Parkinson's, they actually changed the guidance they have with Parkinson's medication. So even before I start prescribing for somebody, I have to think of several things, even before we look at the drugs that are available. The first thing is the individual symptoms. As Neil said, everybody is different. I've done this job now for 23 years, and no two people are the same. People present differently, have different symptoms, have different priorities and worries they have regarding their symptoms. And it's really important that I, as a practitioner, understand what those individual symptoms are and what bothers people the most. I also have to understand other conditions that you might have. So very few people just have Parkinson's. So lots of people might have other conditions, whether it be heart or diabetes or anything else at all. So it's really important to understand what other conditions you might have and how those are treated. And even again, you might not have a condition, but you might be taking other medication or supplements that you get over the counter or from the internet or from your local supermarket. So all those drugs I really need to know about and understand about, because if I'm prescribing a medication, I need to make sure there's not going to be any kind of polypharmacy or interaction between the medications you might be taking. So it's really important you talk about any medication, not just prescribed stuff, but anything else that you might buy over the counter from anywhere else with your clinician and with your prescribing person. It's also really important to understand your lifestyle and your treatment goals, because I need to know what you want to do. I want to know what you would like to get out of the medication and what's most important for you. If you're working still, then it may well be that you don't want to be taking medications lots of times a day, and then once are the options what you want. But there are other people who want to have activity at certain times. But again, everybody kind of have a different lifestyle or different patterns of the day. So it's really important to understand what it's important to you and what you hope to get out of the medication. I also have to talk to you about what the potential harm is for the medications, but also the benefits of the medications, so you clearly understand those. So even before starting medication, it's really helpful for you to go and have a look at those. And I always signpost people to the Parkinson's UK drug treatment and Parkinson's booklet. That's a really nice booklet. You can go away and have a look at it in your own time, have a read about it, and have a look at the different options that are available to you. So in the NICE guidelines, for anybody who's newly diagnosed with Parkinson's, there are what we call first-line treatment options. And these are the medications that we'd use at the very beginning of your journey with Parkinson's. And there are 3 different classifications. The first one is levodopa. And I'll talk about these in a bit more detail in a second. Then you've got dopamine agonists. And the third one, you've got monoamine oxidase B inhibitors. Now, levodopa, this is the gold standard medication, if you like. This has been around since the late 1960s. And this medication really is what we call a precursor to dopamine. So that's the chemical that most people are missing with Parkinson's. So you take levodopa, and it comes in 2 formats. It comes in a tablet format, which is co-carbidopa. That's its real name. That's its generic name. It has got other brand names you might have heard about, Cinemet or Caramet. So co-carbidopa is the first one. That's in a tablet format. Or you've got cobeneldopa, and that's a capsule. And that's, Madapar is another name you might have heard about. So you'll either take that capsule, that tablet, it'll get into your blood system, it'll get up to your blood-brain barrier, it'll get to your dopamine receptors, and it'll convert itself into dopamine. So it's directly replacing the chemical that people are missing. So it's still the best drug we've got available to us today, been around the longest, probably the best tolerated, and again, it's probably got one of the least side effect profiles to it. So it's a really good drug still. Next class, we've got our dopamine agonists. Now, the dopamine agonists have probably been around for the last 20 years. We had some older dopamine agonists in the past called ergot-derived ones, called cabergoline and pergolide. Some people still have those, but the main ones that we've got these days are ones probably called pramipexole or ropenolol or reticotine, that comes in a patch format. Now, the way that the dopamine agonists work is slightly different. So they mimic the effect of dopamine. They make your brain think you've got more dopamine floating around. So they try and enhance that version of it. So they're very good because, again, they're once-a-day versions. And again, they're very easy to take and very easy to titrate up. Our third line are the monoamine oxidase B inhibitors. So unfortunately, there are a number of enzymes in your body that will break down levodopa or dopamine far too quickly and waste it. So the whole point about taking this medication is that it stops that breakdown too quickly. And it makes the best use of what you've got. So you're still producing dopamine yourself, but just not enough. And if that's being broken down by these enzymes, and you're wasting that. So by taking an MAOB inhibitor, it stops that breakdown too soon. But also when you're taking medications like levodopa, that gets broken down by these enzymes. So again, taking that MAOB stops that breakdown too quickly. So basically, the 3 treatments we've got for Parkinson's early on are trying to look at that chemical imbalance that's going on with the Parkinson's. You can either replace it with levodopa, mimic its effect with the dopamine agonists, or you can try and keep what you've got around for longer with an MAOB inhibitor. So the NICE guidelines suggest if you've got motor symptoms, so if you're bothered by stiffness or slowness, problems with dexterity coordination, if you're having difficulties with your movements, then actually levodopa is the best drug there is to solve those symptoms for you, improve those for you, all right? It's not great for tremor particularly. Not everybody gets very good response with tremor, as with any of them. But certainly the NICE guidelines suggest now we should be using levodopa of anybody in any age if you've got motor symptoms. If you've not got motor symptoms, though, and they're not bothersome to you, we can offer you any one of those 3 choices. So you can have levodopa, a dopamine agonist, or an MAOBI inhibitor. It's really up to yourself about what you want to do. And the important thing is you have a chat with your healthcare professional, your prescribing professional, talk about those different options, what they all do, how they all work, thinking about your lifestyle, your symptoms, your condition, your even day-to-day routine, and what's best for you. And between you should be working in partnership here to work out what's the best treatment for you, and should be fully aware of that. There are particular side effects that they have to tell you about with any of the classes of medications, and that's impulse control disorder. And unfortunately, that can happen. And I think we see about 20% of people that we look after with Parkinson's will have some sort of impulse control disorder. And this means gambling or spending or increased libido or increased kind of like repetitive activities. If you're younger and if you've got a compulsive behavior to yourself already, or if you've got an addictive kind of personality, so it may be like smoking or other activities you might have done, you're actually at greater risk then of developing an impulse control disorder with a dopamine agonist. So again, you'll have a frank conversation with your prescribing professional about your lifestyle, about what kind of behaviours you've been having in the past, to work out, are you at greater risk then of getting those behaviours on these drugs? Because they can be really devastating, not just to the person with Parkinson's, but also to people who are around them, their loved ones, family and friends. It can have a real impact. And unfortunately, I have seen that over the years. The medications can also cause, for some people, increased sleepiness. Now, this can happen, obviously, with any of the medications. We have to warn you about that, particularly if you're driving, and particularly if you're using like machinery or things that could actually have a real impact if you end up feeling sleepy. The other side effect we have to tell you about is hallucinations. Now, of course, these can happen for anybody with Parkinson's, unfortunately, but the medication we certainly know can make that a lot worse. So by talking to you about these side effects, hopefully it opens up that dialogue, because if any of these symptoms do occur, you'll come back and tell us about them. So that's what NICE guidelines tell us. They tell us that for the first line treatment, we've got those 3 options available to you. If you've got motor symptoms, you should be using levodopa. If the symptoms are not really bothersome to you, you've got any of the choices, and you're meant to have information and written information as well, oral information about choosing what medication to have. For me, also as a prescriber, I teach all the time the Royal Pharmaceutical Competency Framework. And that's something that all prescribers should be following, not just nurses or physiotherapists, but doctors as well. And in that, there's a whole section about prescribing governance, making sure it's safe for individuals to take medications. So before you start any medication, it's really important that we make sure we talk to you about what the drug is, how it works, how to take it, potential side effects, the benefits you'd hope to see from the medication, the review process. So when you start taking it, who's going to review you? Is that going to be the same person who prescribes it? Is that going to be somebody else? But you should understand who that review process will be with, when it will be, and how it will be undertaken. Is it going to be a phone call or another reviewing clinic? For me, there is no rush to start a Parkinson's medication. You've got time to think about this. And it's really important that this is a shared decision. It's not a decision just done by the clinician saying, all right, I'm going to put you on this, without any of that information that goes along with it. Because if you don't understand how it works, or what it does, or what the benefits should be for you, then how do you know if it's working properly? And often people don't take them correctly. And if you don't take them correctly, again, they're not going to work for you, and you'll get disappointed with those medications, and then you'll lose heart in that and think they're not working properly. So for me, it's about having a really honest discussion with your prescribing professional. They should be following those NICE guidelines about offering what should be available, but also following competency guidelines for prescribing to make sure that you've got all the right information that you need, not only for that bit, but also moving forward for the review process, and also make sure you've got that kind of safety netting in place if there are problems occurring. There's a lot of things to think about, I think, when you start medication. It can be daunting, but certainly the healthcare professional should guide you through that, and you should be given time to do that, not rushed in one consultation if that's not what's appropriate for you.
That's extremely helpful, Annette. Thank you very much indeed. I was particularly struck by your stressing the need for a partnership and shared decision-making with your clinician, which is a point I think we'll come back to a number of times throughout this podcast. Turning to the rest of the panel, maybe starting with you, Nick, I'd be interested to know whether you're on medication. If so, when did you first start? Who advised you to take the particular medication you're on, etc.? Could you just tell us a little bit about that?
Of course. I kind of started on medication fairly soon after being diagnosed, and for various reasons I ended up seeing 2 different neurologists who both advised a different medication, which was quite interesting. And I got the sense that it was more about their personal preference. They thought the best drug at the time for me was that drug. But actually, going back to what Annette said, unfortunately, I wasn't in the good position of having that kind of discussion about it, saying what was the best drug for me, what fitted in my lifestyle. I was working full time, and I still am. I take a drug now currently 4 times a day, which is fine, and I'm pleased with how it's working. But again, there's a bit of frustration. Actually, I would have perhaps preferred a once a day tablet. That might have been easier kind of to remember and to kind of get to get used to. But thankfully things, the drugs are working fairly well for me so far. So, but that initial conversation, I think, probably could have been better.
Yeah, that's very helpful. Thank you, Nick. Maybe across to you, Hema. Could you tell us a little bit about how that started?
Right. Okay. Like Nick, I was started very early with the levodopa Sinemet and various other medications very quickly because they made me very nauseous. So I've now take various combinations of medications, primarily, obviously, Sinemet, but Rosagiline, as well as sulfidamide and numerous other medications, Madapar. But the point I think for me has been difficult is that due to me being vegetarian, I think it hasn't helped. My diet has a big impact on these medications, and the nausea has been a big issue for me right the way through. And the pain in Parkinson's and the pain drugs and the impact they have on the Parkinson's medication, and they don't interact very well. So I think it's all been trial and error. But I'm stable at the moment.
That's very helpful as well, Emma. Thank you. And Kerry, I'll just go to you. Could you tell us a little bit about whether you're on medication? If so, how did it start for yourself?
Yes, when I first saw the neurologist, I'd, like everyone else, seem to have had the symptoms of Parkinson's for several years before it was actually diagnosed as Parkinson's. And when I eventually walked into a neurologist's room, he actually said, I know what you've got before we even get any further, but obviously you'll have to have another scan. So I had a DAT scan at the time, which showed categorically what it was. And I wasn't really given a choice at the time. I was in such shock when he told me that I didn't really get much of a conversation with him about what he was giving me. And he suggested Rapinarole, for want of a better word, which, to be fair, has been excellent, but I now have to have other things as well during the day. But I wish, as Annette was saying, I'd had that opportunity to have a bit more of a conversation with him at that time, at the beginning. I now have very good conversations with him, and the nurses are excellent. But at that very first initial stage, I could have just done with him, perhaps explaining just what Annette has just explained, which is really categorically stated what it is, and I'm very grateful for that clarity.
Thank you, Kerry. Finally to you, David.
Interestingly, I had a very similar experience to Kerry. I had been presenting with symptoms for about 6 years. I was living in Dubai, and it wasn't until I'd had a few days on the trot of full-body convulsions that I decided to see a neurologist. And I booked in to see a German guy in the Canadian hospital in Dubai. And as soon as I walked into his room, he said, I know exactly what's wrong with you, but let me ask you a few questions first, which he did. And he turned out, of course, to diagnose me as having Parkinson's.
We've touched a little bit on side effects. I'd like to come back to that and throw that open to the panel, really. We've touched on a few examples. Does anybody want to share any other side effects they've had they think might be helpful to people with Parkinson's listening to this call?
Yeah, I get dyskinesia I've been suffering from occasionally when I've had to up my meds because Rapinarole, for example, I've been experimenting with different levels according to the doctor, with the help of the doctor. And if I have just too much, it makes me so stiff. So I've now come back down again, and we are experimenting with the Sinemet levels now to try and get that. But it was a major problem. I couldn't actually turn over in bed or get out in the morning. But that is now receding, thank goodness. And I do a lot of exercise, so that is definitely helping me as well. So trying to work along with the medication. So it has been a problem, yeah.
Yeah, Annette, you talked about 20% of people suffering from compulsive behaviour disorder. Is dyskinesia also very common?
Dyskinesia is abnormal movement. It's too much movement that somebody gets. And that often happens as Parkinson's progresses a little bit more and the dopamine receptors in the brain become more damaged. They're like storage facilities, if you like. So not only do they produce it, but they store the dopamine there, ready for it to be, released as and when you've got movement that needs to have that happen. But after time, your storage production area in the brain just isn't there anymore. So unfortunately, particularly levodopa products, unfortunately go straight through that kind of center within the brain and then blast receptors. You've got too much movement ongoing. Not everybody gets dyskinesia. When I first started, I think we used to use lots of higher doses of medication, particularly the levodopa, so we did see it more. I think now that we use combination therapies a lot more, so you might have a levodopa that's going there several times a day, then you might have your MAOB once a day, and you might have a dopamine agonist as well. So having the different methods and the different ways that these control your your dopamine levels is better, and certainly helps to reduce the risk of things like dyskinesia. For some people, though, you're going to get it. Unfortunately, it's a side effect of medication. But for many people, they'd rather have the dyskinesia and the extra movement than not enough movement. And sometimes that's a kind of payoff. There are more medications we can try and use to dampen down things like dyskinesia, like amantadine, but that's yet another medication with another risk of side effects. But again, it's having that frank discussion about what you want with your prescribing, individual about, the lifestyle that you want to lead and the activity you want to do is really important.
And given our particular focus on younger persons, I guess by definition, given that those individuals could be on medication for decades, something like dyskinesia could be more of an issue for that sort of population?
It can be, and obviously it can be really tiring and really wearing. With the dyskinesia, I think because you're on the go all the time for many people, it can be like running a mini marathon virtually every day. And again, it's about making sure then you're eating properly and your weight's okay. Again, it can be more one of those symptoms that's embarrassing or uncomfortable for people. It obviously can cause pain and discomfort. So if you've got aches and pains anyway, then just exacerbate those things. But as I said, it's that careful kind of tweaking around for some individuals and using the combinations that we've got available to us to try and smooth things out. What we're going to try and do is have a nice, smooth motor, dopamine supply. And unfortunately, with Parkinson's, what we don't want to do is have that pulsatile effect. So the smoother we can have it, the better. And the less, hopefully, side effects we've got within that.
On that point, Annette, isn't there a danger also of blaming everything on Parkinson's?
One of the things I remember, and I think we mustn't forget it, is how scary potentially taking that medication is. I remember, soon after I was diagnosed as a relatively young person of 42 in terms of Parkinson's, thinking, I'm going to have to take this tablet, I'm going to have to take this tablet or some tablets for the rest of my life. And I just almost remember standing in the kitchen with that first tablet thinking, right, here we go, this is it. And I think that can be a scary time. We don't know exactly how the tablets are going to affect us, how whether they're going to cause side effects and how well they're going to work. So, it's a scary time. And I think we need to get as much information and be as prepared as we can for that moment, I think.
Yes, well said, Nick. And I know, Kerry, you've been talking previously about the sort of pressure on individuals with Parkinson's to take as much medication as they can to some extent to improve their situation. Do you want to say something about that?
Yeah, I think I've been trying to sort of maintain my levels since I've been on medication by not increasing it too much. But when I go to the GP, sort of very much of it looks at what the neurologist says and sort of suggests perhaps I can go up another 2 milligram or whatever. Well, that doesn't sound a lot, but it makes a heck of a difference. And I've now learnt to temper myself and say no. I mean, it's very good, my doctor, please don't get me wrong, but I think he just needs to listen to me a little bit more. I'm the one taking it, and it affects everybody very differently. So I've got a bit more of a dialogue now.
I'm very lucky in that respect. My GP doesn't hesitate to contact the Parkinson's nurse if he doesn't know anything about Parkinson's. And she's more than happy to fill him in.
Yeah, I was just going to say that for me, pain in Parkinson's has been a massive issue. The GPs deal with the pain management far more than the Parkinson's medication. So in terms of my morphine and morphine patches, other the tramadol and everything else, the GPs don't really understand how they interact with my Parkinson's medication. So I think that there needs to be much more connectiveness between the Parkinson's, the neurology department and GPs in terms of how they manage our medications.
Thank you, Hema. Is this something that's quite common, Annette?
It is, and it's just trying to make sure that you've got, at one point you've had one person prescribing for you, and that'd be the GP. Now, often people have got multiple professionals who are all prescribing different drugs and are looking at people very much in their own little silos, and they're not thinking holistically about what's going on. We know with the pain medication, it can impact on Parkinson's, it can impact on bowels, and can that have an impact on whether Parkinson medication works? So I think it's just about, again, joining up those dots, and having those conversations from my perspective with those other prescribers, particularly the GP, about what's the best thing, how can we work together. I mean, what I would say is when I start anybody on any new medication, whether that's they're newly diagnosed or they're later on down the line, I'll always ask them, what do you want out of this treatment? What are you hoping this treatment will do? What are the symptoms you've got now that are really bothersome to you that we want to get rid of? And I'll always get people to sit down and write down that little list themselves and then put that list away. We'll start somebody then on that treatment and then we'll review that the next time round. Because it's really difficult if you ask somebody, well, what were you like, a couple of months ago that you started medication for? And often it's like, I can't remember what I was doing yesterday, let alone what I was doing 2 months ago. So it's really important that we are realistic with Parkinson's medication. And unless we have some sort of measures about what increases and what improves, then we really struggle to understand, is it really helpful to people? Because some people just say, I'm not really sure if the medication is making a difference. I'm not sure it's really helping. And this could be things like symptomatic things. So if you're having problems doing up buttons or zips, or if you're having difficulty with handwriting, or if you're tired particularly. But we can do some objective measures as well. So we can look at, your walking speed. We can have a look at how quickly you can do certain activities that can help to measure that and show that. Because sometimes I don't think we all appreciate the impact the medication can have. And you've got to remember that with all these Parkinson's drugs, for example, levodopa takes at least 5 weeks, if not longer, to get into your system, to get you up to a proper medication, level. With the dopamine agonists, it can take several months to get there, and for the MAOBI, risadrilene or, selegiline, again, that can take a good 2-3 months to actually get into your system properly. So none of these drugs are really quick fix, but it's really important to understand what you want out of it, have that little list, then we can review that afterwards. And everybody should really should do that, because that really helps understand, okay, then what's it doing for you?
Can we just explore this area of managing and measuring symptoms a little bit more closely? Just going back to what you said a few minutes ago, Annette, I know, for example, to start the ball rolling, I use a Fitbit, which is incredibly valuable in monitoring a number of things, including sleep. And it's amazing when you look at your sleep patterns over a 6-month period, how your kind of memory is different to the reality and how that compares to what's actually happened. And the reality, just to bore you with my own situation, is over the last 3 or 4 years, my sleep patterns have basically remained about the same. Although I kind of think, there's a danger you kind of concentrate on the negative days and the negative nights, if you like, and think they're getting worse, but the data shows something different. Well, that's my example, but does anybody have any others they'd like to share with us?
One good example I have, Neil, is Parkinson's UK non-motor symptoms questionnaire. You can download it from their website. It's very much old school. It's a piece of A4 paper, but you can tick the boxes of all the symptoms you have had over the last month, 2 months prior to your appointment with the Parkinson's nurse or Parkinson's specialist. They can address a lot of these symptoms through medication, and the non-motor symptoms are a lot more numerous and bothersome and disruptive than the motor symptoms often.
Yeah, that is very helpful, David.
Absolutely.
Hema, I think you keep a diary, don't you? Do you want to say a little bit more about that?
I was just going to say, I keep an online diary because I can't write anymore, and that I just show it. Take it on. It's on my phone, and I just show it to the neurologist or to the Parkinson's nurse, and that just sums it up in a few minutes rather than you having to remember everything when you go to your appointment.
Yeah, really helpful.
That's a good one, yeah.
One of the things which I find helpful, I think, is, and again, we probably forget about this, is particularly if we live with someone, is asking your partner or husband or wife and saying, actually, how do you think I've been? Because sometimes when we're the person that's suffering from Parkinson's, we live with it day-to-day basis. Sometimes people, we see our relatives, our family, they can have a better opinion. They can say, actually, you look better than you did a couple of months ago. That's, the tablet's obviously working well, or actually, you don't look quite so well. I think that gives us a good impression about how we're doing, or we can do.
Yeah, another good tip. Kerry, how about yourself?
I too keep a diary, and I've kept it from day one, really, from my diagnosis. And I do all sorts of things. I draw pictures and things in there to try my dexterity, the hand movements, that sort of thing. And it's been incredibly useful, I must admit. And I always write my notes up before I go and see the neurologist or the Parkinson's nurse, because I find my articulation when I'm sitting in front of someone is not very clear, a bit like David was saying. But if I write it all out before, I can either hand that over or I can sit and read it. You just sit there sometimes thinking, I'm sure there's something else, but I can't remember what it was. So if I don't write it down, I'm not going to remember next time.
Just going back to you, Annette, you've heard people's examples there. Do you want to just give us your reflections on that?
Yes, I mean, lots of people use multiple different methods. So lots of, like yourself, using a Fitbit. There are the wearable technologies that people can use to have charting how well they're doing and how well they're moving. There are diaries and on-off diaries that people can fill out. I think for me, it's about, I know that the wearing off questionnaire is really great as being part of that process and helping develop that a long time ago. But for me, it's trying to think about the things that are most important to you. Because the last thing I want to do is have somebody bring in a list of problems and actually going through them, but they're not really bothersome, and you get to the bottom of the list or you're running out of time. So for me, it's just about trying to think, before your appointment, having a chat with your partner. As Nick says, it's really important to understand, somebody else that's living with you and seeing you all the time. But sometimes it's also about other people who might not have seen you recently, because, it's such an insidious onset and the progression is, again, insidious. So people don't often see the changes that are happening day in and day out. But also just trying to, prepare yourself before you come into clinic about, okay, then what are the things I want to address? Having that control of that appointment, having control about what the things are bothersome to you, what the symptoms are that are most, causing you most, concern, and make sure that those are properly addressed. And again, for me, it's not being embarrassed. I know that's a difficult thing to sometimes say, but the amount of people who kind of you do the consultation, they get to the door, they hold the door handle, they go, well, actually, by the way, I've got problems in the bedroom, I've got erectile dysfunction. Now, these are really, important things that happen in Parkinson's, for example. So there are the things that we hear about, and it's just about, being able to talk about anything and not being worried about, how that may seem. There are so many, as we said, non-motor features of Parkinson's. There are over 40 symptoms that people can get there. So it's really important that you talk about what's the most important for you, no matter what that is. And I know that as professionals, we can talk about a few of them, and we'll talk, try and prompt people. But we really want it to come from yourself. And I know sometimes you don't know what you don't know with Parkinson's. But again, it's about asking, well, could this be part of it? And again, I think that goes back to understanding Parkinson's itself, and what David was saying before about everything's blamed on Parkinson's. That's why if you've got a problem in particular, it's helpful to ask your health professional about that.
One of the things that I find helpful is another way of approaching it. Is quite often when I see my consultant, he'll ask me, is the Parkinson's stopping doing anything you want to do? And I think that's kind of quite a good way of asking it, because, if you're perhaps trying to do a bit more exercise, but then you're struggling because your foot's not working properly. Actually, we know how important something like exercise is for us, for our condition. So actually, perhaps we need to increase our medications. And I think, asking that question about whether it's stopping you doing anything is another good way of helping you think about that.
For me, I know that we're talking about medication here, but this isn't all about drugs. And there are so many things that you can do yourself that's really going to make a huge difference to how your Parkinson's is and how well your control of your symptoms are. For example, exercise. There's some fantastic evidence now show that exercise really is beneficial to Parkinson's. Your diet, so making sure that you're eating properly and a well-balanced diet, you're not getting constipated. Because, if you get constipated, unfortunately, lots of Parkinson's medication just sits there in your bowel, is not absorbed, is not used properly, and it's just wasted. So if you're not active, again, that's going to have an impact on your bowel and how your bowel works. Things like, fluids. So we know with Parkinson's, it can reduce your blood pressure and lower the blood pressure. We know that all the medications with Parkinson's can, again, lower your blood pressure. Drinking plenty of fluids, trying to keep up your fluid levels, again, is really important. So there are things here that, simple things that we all kind of think we do, but could probably do better, that'll make a huge difference. And so it's not just about the drugs, it's about the whole package, I think, for me. And it's about doing things that you really want to do and really want to enjoy doing, like Nick was saying, and getting your whole lifestyle. So just remember all those other bits and pieces are just important about, rather than just taking the medication on time or regularly.
Okay, we'll just talk a little bit about something different, which is changes in medication. Annette's given us a clear indication at the beginning of the different types of medication available. Does anybody want to say a little bit about the process whereby they've changed their medication, how that came about, how they particularly track their reaction to it, any negative impacts, etc.? And you want to say anything on that?
The only personal problem I've had has been impatience, as we were discussing earlier with Annette. I wanted the changes to happen overnight, or within at least the next 2 or 3 days, and they never did, of course. It would always take a few weeks, a couple of months to kick in. Now that I've accepted that, and I expect that to happen, it's fine. And I know myself, when I wake up in the morning, that today's the first of a brand new period in my life, because the latest drug change has kicked in, as it were. And oftentimes it's just an extra capsule, an extra tablet of Madopar, for example, which was my most recent change. And that's made a huge difference. Because I mentioned to the Parkinson's nurse that I had a daily off period from about 6 p.m. until about 7:30 p.m. And I could almost set my watch by it every day. So she had me put on one extra tablet at 3 p.m. and take them 4 times a day. And within 2 weeks, it was very rapid change. The off period from 6 to 7:30 disappeared. Now I'm on right through till bedtime, which is fantastic.
Yeah, I agree, David. I think it's not just about dosage changes, but it's really important for me about timing changes. And I find quite often that, as many people do, that eating food interacts with the medication. I think we generally know that protein, particularly if you take protein at the same time as taking tablets, it can basically almost negate the effect of the tablets. Well, that's what I find anyway. So I think really important is tweaking the times that you take the tablets, and that's had a real positive benefit in me over the recent years.
Maybe I could just come to you, Annette. We've heard a lot about the timing of medication, how important that is. Could you just tell us a little bit about that from a clinical perspective?
Yes, of course. So this particularly is around levodopa. So that's your Cinemet or your Madopar, your co-carbidopa, your co-benaldopa. So even though it's the best drug we've got, the problem we've got with levodopa is it's short acting. So basically, a dose of Cinemet or Madopar, co-carbidopa will maybe work about an hour and a half at the most. So a normal preparation tablet or capsule will work about an hour and a half. Now, when you first start with Parkinson's, you'll probably be taking about 3 times a day, and it should be roughly spread out between 5 to 6 hours at the very, very most. And that's because the medication will do its bit and bump up your dopamine levels, but also you're still producing your own dopamine as a buffer to get you through to the next medication, the next tablet time. But unfortunately, as Parkinson's progresses, your buffer gets less. So you'll take the medication, but then the next time before the next one's due, you'll be aware of a return of some of those symptoms coming back again. Just like I think Dave was saying earlier on about the return of symptoms at a particular time. And often that's very cyclical. You can look at a pattern for that. And that's if you do a diary, you can see that happening. And the thing is, if you don't take your medication regularly, remember again, a dose of medication takes at least half an hour, 3/4 an hour to start working. So if you're taking it a bit late and then it's got that delayed wearing in, you've got that kind of a delayed, response to medication. So that's why it's really important when you start off taking it, that you try and take it at regular, intervals throughout the daytime. And again, that will be very much depending on what your routine's like. So depending on what time you get up in the morning, depending on what time you, first get moving, but that should be worked out with the clinician and worked out with the prescribed professional. It's not so important, though, with dopamine agonists. They're once a day, as the MAOBs are as well. But certainly with levodopa, taking it on time is really important because that means your body gets used to it, but also hopefully, prevent some of these wearing off or delayed on symptoms that, could happen early.
Kerry, perhaps I could just go to you. I know you were talking to me earlier about this subject of having clarity on what medication you're taking should you be involved in an accident, for example. Or
that. A paramedic friend of mine advised me to download a health app, which I think is available on all phones. I happen to have an iPhone, but it's available on all phones. And basically, you put in there all your medical information, and you actually put it as an emergency code on your phone. It shows you how to download it. It's very, very simple. It has to be for me to do it. I'm rubbish. And basically, if you're in an accident or you're in hospital and you couldn't speak properly, someone can open up this app for you. They don't have to have your ID to get into your phone. They can just open it up as an emergency code. and in there is all your, you can write down the times, what you're on, also your blood type, all sorts. It's amazing. He just highly recommends it because paramedics will always check for phones first in accidents to try and get IDs on people. So whether it's an accident or you're going into hospital and unable to speak, which sometimes I know we have problems with Parkinson's, it helps. It's just something you can show, and it alerts everybody to what you're on and what's wrong with you. And basically it couldn't be more highly recommended by this paramedic. I recommend everybody looks for the health app on their various phones.
Thanks, Kerry. That's a really good tip. Talking about this subject of a Parkinson's patient being hospitalised, Annette, and the importance of taking medication on time, how is that addressed from the clinical side?
It's always difficult, Neil, because often people on the wards don't fully understand Parkinson's or the importance of taking medication on time with Parkinson's medications. What I would say to you is make sure that if you go into hospital, you've got a clear list of what you're taking and the times of that are really clear. And that's passed on to the doctors. Also, make sure you take a whole package of your own medication with you, so you've got some medications yourself. Because sometimes they're not on the wards or not in regular ward stock. So what you do is making sure if you've got your supply medication, they can still be given to you. We're in hospital. Parkinson's drugs are now classified as critical medications, which means they have to be given on the time that they are prescribed. And that's when it's really important that whoever kind of what we call clerks you in, and that's often a doctor or a nurse practitioner, and those are the ones that will then put the timings of those medications on that drug chart for you, that they're accurate and they're up to date. If there's any kind of question around that, if you think they're not right, make sure that you or one of your family members or somebody else says something to the ward staff that can be changed as quickly as possible. What I would also say, if you've got any problems around that, then please contact your Parkinson's service, specialist service, because they can talk to the ward staff, get that amended and altered and changed as needed. It is difficult when you've got a ward full of people. Obviously, the medication rounds, they are set times. But for somebody with Parkinson's, it's really important they get drugs when they need them. And that's why they are these critical medications. So make sure you take your medication with you, a list of medication, and any problems, raise it really early, because then we can do something about it.
Thank you, Annette. That's very helpful. David, you wanted to say something?
I just wanted to add to Annette's point, Parkinson's UK do a very nice toiletries wash bag, which is designed for taking your drugs to hospital in. And it contains various get it on time stickers to put on your drug charts. There's also a laminated cardboard clock to stick on the wall above your bed to remind the nurses of your next dosage when it's due. And there's information leaflets about why you should take drugs on time, meds on time. It's very useful. It's free. You can get it via the Parkinson's website or the Parkinson's local advisor. Maybe even your Parkinson's nurse has some in stock.
That's excellent, David. I've not heard of that. That's very good advice.
It's very useful.
Okay, we're just coming to the summing up stage of this podcast, and I'd like to ask each of you to give some tips, really, to those who are listening, maybe those with Parkinson's or those of the clinical community. Perhaps I could come to you first, Nick, to get your thoughts on what you might give as advice or tips to any of those populations.
I think for the healthcare community, I think I'd want to remind them that that they have lots of expertise in lots of ways, but we live with Parkinson's 365 days a year, and we know what it's like for us. And as we've talked about already, it's all very different. So we're the experts. So make sure you ask us how we are, and we need to be prepared to kind of give the right answer. And I think for other people with Parkinson's, I'd want to advise them to make friends with their local pharmacy. One of the things we do have a chance to kind of decide, actually find a good pharmacy, find a good pharmacist that you can talk to, and make sure that they can work for you to get availability to your medication, that you don't run out. And obviously we know how important that is.
Excellent. Thank you, Nick. How about you, Hema? Any final thoughts from you?
Yeah, I was just going to say as a final thought that anybody out there with Parkinson's, do not be embarrassed or ashamed of our illness, because that was a big thing for me when I first got diagnosed, and asking for help. Please ask for help, because this isn't just a physical illness, it affects your mental illness badly as well. So please ask for help and join a local group if you possibly can.
Excellent, very well put. Kerry, any final thoughts from you?
Yeah, I'm really backing up what Hema says, really. I've got a local group of Parkinson's people, and most of them have said they would not have got out and about unless we formed this group. So it's been essential. And also this COVID lock-in, we've kept each other amused with little phone calls, and we met up in the park as a social distance meeting. It's absolutely essential that you talk to other people and get, make friends. You're not alone in this at all. We're all there together.
Thank you again. Very well put, David. Final thoughts from you.
Yeah, I would just like to underline Kerry and Hema's point before her. We're not in this alone. There are lots of people out there, and you don't have to endure this journey alone. It's a very lonely place if you do try to do so. I find the local groups tend to bring individuals together because they have Parkinson's. It gives people a reason to keep going. For the healthcare practitioners, one tip I would give them is build on Nick's point. Who better to understand Parkinson's disease than people with Parkinson's themselves? It's often referred to as the invisible disease because not the first time I've been asked, are you sure you have Parkinson's? You look so well. Or you don't look like you're sick.
Annette, the final word to you.
Thank you very much. I suppose I was saddened to hear that everybody's experience when they're first diagnosed is not really getting a lot of choice or option. And for me, that's not how it should be. And that's certainly not my practice. If we follow the guidelines that are out there, both from NICE and the RPS as healthcare professionals, then actually we do make sure that this is a partnership approach. This is about information sharing, not just about us information giving. As Nick says quite rightly, you're the expert in Parkinson's. I'm not, you are, because you're the expert in you and how you are and what your lifestyle is like and what you want out of it. And all I can do is help support and guide you in terms of what medications or support or treatments are available to you. So for any healthcare professional out there, medication is such an important thing that we get right, but it's a partnership approach. It's not me deciding what somebody should be going on. That's not how this works. This is us following guidelines that are there for a particular reason, and that's to make sure that this is, what you want it to be, and working in partnership together. So definitely partnership approach for me.
Thank you ever so much. Thank you to all the panellists for joining us, and we'll close there. Thank you very much. Thank you. Thank you, everyone.
Thank you. Then see you guys.
Right. Thank you.
Bye.
During this podcast, there's been reference to both the Younger Parkinson's Alliance website and the Parkinson's UK website. I'd recommend that people seek information there. So finally, thank you for joining us on this podcast. I hope you've enjoyed it. I look forward to talking to you on our next podcast about exercise.